Okay. Good morning, everyone. I'm Shobhit Jagga, and I'm really excited to be presenting my work to you today. Today, I'm going to present my social hackathon project contribution based budget allocation for breast cancer mortality reduction. The proposed solution consists of a prediction model for predicting breast cancer risk, along with the contributions of various risk factors, and guide policy making towards that. I will begin with discussing the relevance of the problem that we are trying to solve, and then I will move on to the model and prototype details along with the future developments. So, breast cancer in Mexico has a very high incidence rate of around 40 cases per 100,000 women. And not just the cases, but the mortality rate has also been on the rise in recent years. And with the recent research establishing the causal role of pollution from different sources in breast cancer, it is important for us to understand the role of healthcare and pollution towards this and deploy solutions to tackle it. Before moving to the model, I will discuss the confounding bias of locality types in a municipality that is present in our dataset. So, health studies typically check age standardized mortality rates instead of crude mortality rates of a population, since age distribution of a population confounds with the number of deaths. Here, I show that locality type is also a confound in standardized mortality rate calculations. A locality basically is just a subdivision of a municipality in Mexico, and its type corresponds to the population that resides there. As in the figure, type 1 means less than 1000 residents residing in the area. Greater than 7, for example, would mean greater than 15,000 residents in the area. I will explain this confound by an example of two municipalities in Mexico, a home in Sinaloa state and Durango. We can see in the left figure that the crude mortality rate of a home is higher than Durango. But when we divide the municipality by locality types less than equal to 7 and greater than 7, we see that a home now has lower mortality in both the location types. But since its population in low population areas is higher, crude mortality is higher for this area. Similar to the age group adjustment done in SMR calculation, we see a need for adjusting location type distribution as well before we actually compare populations. I have adjusted uh, this confounding variable whenever I calculate expected deaths for a municipality. Let us now focus on the details of the system and the prediction model. So this is the backend flow of the system. There are different sources which feed their input to the prediction model. These sources are different health resources, marginalization of an area, stationary risk sources like brick factories, carpentry, biomass, etc., water sources, and emissions. These feed the model risk of a municipality for a particular year to the prediction model, which outputs the risk prediction for the municipality for next year along with the contributions of those risk factors that were input. The risk prediction and factor contributions are then used for optimal budget allocation. The constraints of input risk sources are also fed to the budget allocation flow as we see in the diagram. These constraints are in terms of the required budget for working on those input sources. For example, what is the budget for setting up new hospitals in the area or reducing the concentration of chemicals in water sources in the area? The input risk is modeled by either the number of sites, as in healthcare services, and stationary risk sources like the number of brick factories, manufacturing sites, or by the concentration of carcinogenic chemicals in the sources like water or emission sources. We also have normalized marginalization values for municipalities, which can be used for modeling resource accessibility and awareness. I define the outcome variable which I am going to predict by the model to be the excess deaths, which is expressed as observed minus expected deaths for the municipality for the next year, which I will be predicting using the current year's risk factors. I choose the difference of observed minus expected deaths instead of the ratio as we do in SMR calculations because firstly any effort in pollution decrease for any emission source, stationary risk source, a water source does not depend on the population in an area, and it directly reduces the excess deaths. So, considering the percentage decrease of deaths by such efforts can lead us to wrongly allocate our funds. Also, areas with low population and low expected deaths lead to noisy SMR values, which would be handled if we take the difference. So, it is more intuitive from policy making standpoint also that we try to target more affected people. Okay, regarding the model selection, I choose a random forest model for prediction as there is non-linearity present in the input data, which I observed by the high omnibus and skew score. These models are also able to handle noises in data and hence suitable for our datasets, which have high potential of noise. Contribution based modeling of input variables is also useful and in our allocation methodology and provided by this particular model. We see that the model explains a significant 62% variance in the test set, but the difference in train and test set results indicates some overfitting, which is one of the future work of this study. Okay, so now let's have a look at the front-end dashboard flow, which is intended to be used by the policymakers and domain experts to visualize risks in different municipalities across years, along with the contributions of these risk factors that we discussed. Okay, the map tab here shows color-coded risk prediction for municipalities from green to red, with red being high risk. On clicking on a municipality, we can see the prediction and contribution of factors. Here, La Paz has nearly 19 more deaths than expected, and the major positive contributors are marginalization and emissions. Outpatient consultation and hospitals have low negative contribution. We can add new sources of all the input types in the Add New Sources tab. Let us add 100 hospitals to La Paz to see the effect. On adding the sources, the model re-evaluates the prediction and contributions. We can see that the prediction, if we click on La Paz, we can see that the prediction for La Paz has dropped significantly with high negative contribution of hospitals. Okay. Lastly, in the budget allocation tab, we can view optimal budget allocations for input constraints for a municipality. The figure shows a sample allocation where we provided total budget and the maximum and per unit cost for all the input sources to get an allocation of resources and budget for La Paz municipality. As future developments, firstly, a discussion with domain experts and policymakers is essential for refining the design for budget allocation across departments and states, and to rethink about this to expand it to the national level. And as we saw a decrease in the model's performance from train to test data, a more robust handling of data noise, data incompleteness, and overfitting is required. Currently, the risk is modeled according to the risk sources in a particular municipality, the effect of those sources on neighboring municipalities, and also the effect of population migration from one place to another remains to be studied. So, to summarize, I propose a prescriptive framework for guiding resource allocation and policy making in an informed direction. Thank you.